Actually, the subject of my lecture is about the novel antifibrotic and the anti-inflammatory medications, which can be used in diabetic kidney disease. Actually, these lines of management, in spite of all the studies and the clinical randomized controlled trials which have been done in diabetic patients, still there is a lot of patients who can progress, and the progression of diabetic kidney disease cannot be stopped. And as we can see here from the randomized controlled trial, which have been done in the last 20 years, in the first 10 years, there is only a paucity of trials which are done, but in the late 5 years, there is a lot of randomized controlled trials which are done, including many types of drugs. The diabetic kidney disease involves two pathways. We have the proteinuric pathway, in which there is hyperfiltration and the proteinuria, and the ACE inhibitors and sodium glucose co-transporters inhibitors are well-known inhibitor of this pathway. But we have the non-proteinuric pathway, which are going to present with decline in the GFR. In those patients, it's the renal impairment or the decline in the GFR is due to vascular and tubulointerstitial lesion, and the ongoing inflammation may be the pathogenesis for this. In non-proteinuric patients, it has been found that the serum concentration of markers related to tumor necrosis factor alpha are predictors of disease progression, and it should be noticed that still there is higher rate of renal of GFR progression more than the normal rate. To revise the pathogenesis of the diabetic kidney disease, we have the metabolic factors through the effect by the advanced glycation in the products, and we have the metabolic factors through the glucose metabolic byproducts. We have the hemodynamic factors causing systemic hypertension and increase of intraglomerular hypertension. We have the growth factor, especially the vascular endothelial growth factor, and as we can see here, we have the pro-inflammatory and the pro-fibrotic factors acting through the macrophage activation, innate immunity, and the complement system. The diabetic kidney disease affects every part of the nephron, and every cell can be affected. There is glomerular hypertrophy, mesangial cell proliferation, podocytopathy, endothelial dysfunction, thickening of the glomerular basement membrane, tubular epithelial mesenchymal transition, progressive accumulation of extracellular matrix, all of which is going to end by renal fibrosis, which can involve the glomeruli causing glomerulosclerosis and tubulointerstitial fibrosis as well. The renal fibrosis starts by the injury to the kidney, which can be through the hyperglycemia itself. It can be through the angiotensin 2. It can be also through the reactive oxygen species, and it will cause an increase in the inflammatory cytokines, which will stimulate the intracellular signaling pathways and the different pathways leading to the affection of the epithelial cells, endothelial cells, and mesangial cells. And by the release of transforming growth factors and the connective tissue growth factor, there will be formation of the myofibroblast with increased collagen formation and extracellular matrix accumulation. Meta-inflammation contributes also to the pathogenesis of diabetic kidney disease. It's some sort of low-grade chronic inflammation, and it has been discovered by the presence of high markers of systemic inflammation, including CRP, high sensitivity CRP, and there is increased level of tumor necrosis factor and the soluble tumor necrosis factor receptors as well. Investigations in humans have demonstrated correlation between specific component of the two arms of the immune response, the innate and the adaptive immunity, with markers of declining renal function, albuminuria, and the lower GFR. As you can see here, the meta-inflammation acts by affecting the endoplasmic reticulum stress, increasing the inflammasome activation with the production of the interleukin 1 beta and the interleukin 18, and there is increase in reactive oxygen species. All of this will end by the formation of glomerulosclerosis and tubulointerstitial fibrosis and dysfunction. The innate and adaptive immunity have been involved also in the pathogenesis of diabetic kidney disease. The innate immunity is the first one which is involved, especially with the macrophage. And as we can see here, and that we have one with the release of certain chemokines. We have here the monocyte chemoattracting protein, and it is the most potent chemokine that promote inflammation in diabetic kidney disease, and it's associated with more decline in participants with type 2 diabetes. This has addressed the research against the monocyte chemoattracting protein by the NOX-E36, which has been used, and it was found to reduce the proteinuria. Blocking chemokine receptors also are taking place in the phase 2 research controlled trial. As we can see here in the pathogenesis of diabetic nephropathy, there is mainly involvement of the macrophage M1 phenotype, which will lead to production of the pro-inflammatory cytokines, and there is less production of the M2 phenotype, which is mainly anti-inflammatory phenotype. This was a simple introduction about the pathogenesis, just to understand what are the lines of management of the diabetic kidney disease. As you can see here from the slide, that we can classify the lines of management into 3 lines. Already the current treatment, which includes the control of the hyperglycemia and the high blood pressure, whether through the ACE inhibitors or ARBs, or through the already emerging drugs like the DPP4 inhibitors or sodium glucose co-transporters inhibitors, and recently by the presence of the mineralocorticoid receptor antagonist, anti-insulin receptor antagonist. But in the emerging lines of treatment, there will be involvement of the different intracellular signaling pathway, as we are going to see later on. In this slide, these are the different types of problems that are faced in diabetic kidney disease. Is here on the on the right side, as we can see in the fibrosis and the inflammation. The main lines of treatment include the RAS blockers and the mineralocorticoid receptor antagonist. This is also another source of mentioning of the medication, and still mentioned that the RAS blockers are the main line targeting the inflammation. The renin-angiotensin-aldosterone system, apart from being involvement for the control of hypertension, it has been shown on the animal studies that it can affect the mice and the rodents through different pathways, mainly through the inhibition of the kidney in the kidney fibrosis. This is different from the ARBs. And the administration of angiotensin converting enzyme has been shown to increase the concentration of plasma ACSDKP 5-fold, which is antifibrotic through the inhibition of transforming growth factor beta. From this slide, we can see that the pathway that we all know is the conversion of the angiotensin to angiotensin 2, and by the effect of the angiotensin converting enzyme, it ends by the formation of the angiotensin 2, which act on the angiotensin type 1 receptors, producing inflammation and fibrosis. But on this slide, also we can see that there is a side way which involves the angiotensin converting enzyme 2, which changes angiotensin 1 to the angiotensin 1,9, which is an inactive product, which will be transformed into the angiotensin 1,7, either through the conversion of the angiotensin 2 directly, or by the conversion of the inactive angiotensin 1,9. The angiotensin 1,7 acts on the MAS receptor agonist, and it produces effect like those produced by the stimulation of the angiotensin 2 receptors, being anti-inflammatory, anti-fibrotic, antioxidative, and anti-proliferative. As we can see here, also the captopril, which is the prototype of the angiotensin converting enzyme inhibitor, acts on the angiotensin converting enzyme through its 2-terminal domain. The conversion of the angiotensin 1 to angiotensin 2 is through inhibition of the C-terminal domain, but through the inhibition of the N-terminal domain, there is increase in the ACSDKP, which is the N-acetylsteryl aspartyl lysyl proline, which has an antifibrotic properties. Also, it has been shown that the ACE inhibitor alone or combined with SDKP inhibited the renal overexpression of the DPP4 and the activation of the transforming growth factor signaling by restoring the expression of the antifibrotic microRNA. Okay, the angiotensin converting enzyme 2 also has been studied by recombinant angiotensin converting enzyme 2 in rodents, and they demonstrated the ability of the angiotensin 2 to rapidly metabolize angiotensin 2 in vivo and to promote angiotensin 1,7 formation. Angiotensin converting enzyme 2 and angiotensin 1,7 mast receptor axis has also been studied, and it could be a potential therapeutic approach for the kidney disease, including diabetic nephropathy. Angiotensin 1,7 has beneficial effects because it can cause reduction in proteinuria, systolic blood pressure, renal fibrosis in association with decreased production of oxidative stress and inflammatory markers. The problem in this angiotensin 1,7 that it needs to be present in high concentration in the urine, but it has short half-life. That's why they by genetic engineering, they produce the acyclic angiotensin 1,7, which has more half-life, and it have a strong antiproteinuric effect as the ACE inhibitor lisinopril, which was used for comparison and limited glomerular fibrosis and inflammation even better than lisinopril. This cyclic angiotensin 1,7 has antiproteinuric effect through the action on podocyte and on the glomerular endothelium as well. So the potential therapeutic application in RAS system in diabetic nephropathy, as we can summarize, it lowers the level of angiotensin 2, it increases the level of SDKP, which is an anti-inflammatory and antifibrotic. ACE inhibitors alone or with the SDKP, it can inhibit the renal overexpression of the enzyme DPP4 activation, transforming growth factor, and the other mechanism as we mentioned before. We all know that the angiotensin or the RAS system, it ends by the formation of the aldosterone. Aldosterone contributes to fibrosis and the inflammation in diabetes in different manner, either through the production of the damage-associated molecular patterns, which will cause tissue injury directly, or through its effect on the cells of the innate immune system and on the adaptive immune system with the formation of the interferon gamma and the tumor necrosis factor, which will lead to the production of renal inflammation and the fibrosis. The mineralocorticoid receptor antagonists are well-known lines of management which are present already and well studied since the 1960s. And it can be used in cases of edema or in cases of heart failure, but it has a lot of side effects, including mainly hyperkalemia and steroidal stimulation like gynecomastia. That's why they produce the second generation of aldosterone of mineralocorticoid receptor antagonist, and the latest one is the finerenone, which is was FDA approved in 2021. Here, the finerenone is the first novel, highly potent selective mineralocorticoid antagonist, which is non-steroidal mineralocorticoid receptor antagonist with less hyperkalemia and less side effect. It has been present in the market just not more than 2 months ago, which is present under the name of Kerendia, and it is present in different concentration. The mineralocorticoid receptor blockage can act through different ways. The most important type is through the activation or the shift in the macrophage phenotype from the pro-inflammatory M1 to the anti-inflammatory M2 with decreased transforming growth factor beta and platelet activating inhibitor, in addition also to acting on the matrix metalloproteinase and the tissue inhibitors of metalloproteinase in addition to better blood pressure control. This is the Fidelio trial, which was the cause that it has been approved by the FDA. It included more than 5,000 patients with type 2 diabetic patients with GFR between 25 and 75, and they have urinary albumin creatinine ratio more than 30, and it has been shown that there is antagonizing of the inflammation and fibrosis with more protection on the kidney. As we can see, as I told you before, this is recent data, and it has been published in the Standard of Medical Care in Diabetes in Diabetes Care 2022, and here it is well shown that it can be the mineralocorticoid receptor antagonist can reduce in reduction kidney disease progression and the cardiovascular events in patients with advanced diabetic kidney disease. This was a cause also that the KDIGO 2022 clinical practice guidelines for diabetes management in chronic kidney disease, which has been published in March 2022, has added, and for the first time, the presence of non-steroidal mineralocorticoid as a targeted therapy, and this was not present before. Zaccarendia, which is the FDA-approved finerenone, the recommendation of the KDIGO guidelines to use the non-steroidal mineralocorticoid receptor antagonist with proven kidney or cardiovascular benefit for patients with type 2 with EGFR more than 25, and non-steroidal mineralocorticoid receptors are most appropriate for the patients with type 2 diabetes who are at high risk for chronic kidney disease progression and the cardiovascular events, and it is better to choose patients who doesn't have a risk of hyperkalemia, and the choice of non-steroidal mineralocorticoid antagonists should prioritize agents with documented kidney or cardiovascular benefit. Other non-steroidal mineralocorticoid receptor antagonists are studied, and some of them are in phase 2 or phase 3 already. Just to finish the system, as we show, there is the neprilysin, which can act also on the angiotensin 1,7 and on the angiotensin 2 for its conversion to the angiotensin 1,7. And the studies had been done on the patients who are type 2 diabetics and have a chronic heart failure, and it has been shown that it can attenuate the effect of diabetes to accelerate the deterioration of the renal function, but no studies has been done on the patients who are having diabetic nephropathy without heart failure. Okay, regarding sodium glucose co-transporter type 2, it has been found also to have an anti-inflammatory mechanism which is beyond its hypoglycemic effect, and as it reduces the level of tumor necrosis factor receptor 1, interleukin 6, and matrix metalloproteinase. Also, it may have a role through its effect on the hypoxia-inducible factor 1. Glucagon-like peptide 1 receptor agonist also has been shown to inhibit the advanced glycation in the products and inhibit interleukin 1, tumor necrosis factor, and monocyte chemoattracting protein, and affecting the nuclear factor kappa beta. All these effects beyond the incretin effect and beyond the hypoglycemia effect. Linagliptin, which is a DPP4 inhibitor, has a unique effect which is not shared by other DPP4 inhibitors, that it will attenuate the podocyte dysfunction, and it inhibits the endothelial mesenchymal cell transition, and it acts also by restoring the messenger RNA, which targets the DPP4 inhibitors overexpression and its interaction with integrin beta 1, so reducing the transforming growth factor beta. The microRNA in diabetic kidney disease, as we see here, that the hyperglycemic conditions will stimulate the profibrotic genes and the antifibrotic genes, and by their effect together, it may overstimulation in the extracellular matrix accumulation will end by the formation of fibrosis. Endothelin receptor antagonist has been used also as an anti-inflammatory mechanism or way of treatment, but a lot of studies have been terminated due to fluid overload. The latest one was the SONAR study, in which it was published in 2019, and it studied the atrazine 10 It was phase 3 double-blind randomized controlled trial, and it included more than 5,000 patients. It was used on top of ACE inhibitors and the RB's inhibition. It has been stopped also due to fluid retention and anemia. It was terminated, but the good in this study that the post-hoc analysis indicated hope that when it is used when sodium glucose co-transporters inhibitors. There is another pathway, which is through the sirtuins in diabetic nephropathy. Sirtuins include our family of classes which act on the NAD-dependent deacetylase, and it has redoprotective effect. As we can see, it acts as an anti-apoptosis, antifibrotic, and anti-inflammatory, antioxidative stress. We have two well-studied sirtuin 1, which act on the podocyte, leading to the activation of the angiotensin converting enzyme 2 promoter, favoring the production of the angiotensin 1,7, and its a positive effect as an anti-inflammatory and the antifibrotic, and it acts also on the endothelial cells, reducing the renal interstitial fibrosis. Sirtuin 3, as we can see here, also it's renoprotective, and it has antioxidant, anti-inflammatory, and antifibrotic effect. Emerging lines of treatment to control the inflammation include the targeting the inflammatory signaling and fibrosis in diabetic kidney disease through the effect on the nuclear factor erythroid 2 related factor by the pardoxolone, and we have inhibition of the apoptosis signal regulating kinase 1 inhibitor, as we have, and the phosphodiesterase inhibitors as well. The phosphodiesterase inhibitor is which is the prototype is a pentoxifillin, has been used, and it can reduce the expression of tumor necrosis factor, interleukin 6, interleukin 10. And here is this pardoxolone. It's not FDA approved yet, but it is a promising factor to inhibit the inflammation through several studies. And also there is baricitinib, which has been used still in animal studies to inhibit the nuclear factor kappa beta through the action on the tyrosine kinase. And we have selonsertib, which is acting on the apoptosis signal regulating kinase 1 inhibitors. All this is through the experimental studies only. And there is another drugs which act also through the advanced glycation in the product inhibitors. The sevelamer that is used for by the nephrologist. It was shown also to reduce the advanced glycation in the product absorption, and has a pro-inflammatory factors, improved anti-inflammatory defense. The pyridoxamine, which is a member of vitamin B, can block the synthesis of advanced glycation in the product also. Other drugs can be used like the protein kinase C inhibitors, but still under research studies. But we have the medications which are used in the interstitial pulmonary fibrosis. There is minimal studies that it can be promising through the reduction in the platelet-derived growth factor and transforming growth factor beta. We have the pyrifenidone, and we have the nintedanib, which is present in the market under the name of OFIV. It can act through the inhibition of the vascular endothelial growth factor and the fibroblast growth factor, as well as on the platelet-derived growth factor. Other medications have been tried like the diacerin, which can block the action of the interleukin 1 beta, and there is low-dose colchicine has been tried also in patients with type 2 with microalbuminuria. The vitamin D receptor activating the paracarcitol has been found also to reduce the infiltration of the inflammatory macrophages. Statin have an anti-inflammatory and antifibrotic effect. Allopurinol also inhibits the synthesis of uric acid and may act through the inhibition of the inflammation. Doxycycline also can reduce the matrix metalloproteinases. Drugs also on the experimental level on animal studies include the nicorandil and the NOX-E36, as we said before. We have inhibitor of Rho kinase and the inhibitor of proliferation of the fibroblast like the tranilast. By the end, we can conclude that the multifactorial origin of diabetic kidney disease and the multiple molecular mechanism involved probably contribute to the lack of response of a single drug in all the patients. The identification of novel therapeutic targets is therefore urgently required in diabetic kidney disease, and it is becoming apparent that the combination of the anti-inflammatory, antifibrotic agents with the newer anti-diabetic agents could effectively combat the complex nature of the diabetic kidney disease. And maybe after the lecture which has been given by Dr. Mona, maybe in the future will be genetic studies which can tell us which pathway is involved in the pathogenesis, like to maybe we are going to have better selection which type of medication can be added to the medication already present. Thank you.